Next is about vidradhi. अर्थात vidradhinam निदानं व्याख्यास्यामः यतो वाचमग्रन्थनन्तरिः सर्व अमरगुरुः श्रीमान् निमित्तान्तरभूमितः शिष्याय उवाच निखिलम् इदं विदृधिलक्षणं त्वग्रक्तमांसमेधांसि प्रदूष्य अस्थिसमाश्रिताः दोषाः शोभं शनैः घोरं जनयन्ति उत्सिताः भृशं महामूलं मृजाबन्धं वृत्तं चापि अथवा आयतं तमाहुः विदृढिं धीराः विज्ञेयः स च षड्विधः पृथग्दोषैः समस्तैश्च क्षतेनापि असुजा तथा षण्णामभिः तेषां लक्षणं संप्रोक्ष्यते. The next part is about the vidradhi. Now, vidradhi, vranashopa, visarpa, nadi vrana, these are all certain of the issues which are related to the similar conditions. The vranashopa and vidradhi, they are two different conditions which we have already referred to in context of Sutrasthana. Vranashopa is when a inflammatory pathology starts at the surface, superficial area. Twag rakta mamsa, it's all. It's a twag mamsa sthai. When Vranashopa is a twag mamsa sthai, when it is limited to the twag and mamsa. When the doshas involved or the pathology goes beyond that, twag rakta mamsa medas or even asti to a deeper level, then it's called as a vidradhi. That's one of the conditions. So when you to say as a vidradhi, it needs to be a deeper condition, one. And the other is it should be localized. The surface of the vidradhi would be raised and the borders would be palpable. Because the borders are palpable, you may have a identification of the shape of the lesion. So shape of the lesion could be vrutta or ayata. It could be circular or maybe rectangular or so on. So borders are clearly palpable and it's a surface is raised. Such a condition is called as a vidradhi, a inflammatory pathology which results in a palpable, clearly borders being clear, and such a lesion is considered as vidradhi. Now, in the current situation, we use the term abscess. Now, the word abscess doesn't specify the plane of the lesion, whether it is in the surface or in the deeper. When there is a collection of the pus, then we call it as an abscess. But to say vidradhi, that depth of the lesion or involvement of the tissue also is a criteria. So you cannot just translate the vidradhi as abscess, though in a good number of conditions it is true. Now, once there is a inflammation occurs, the inflammation is, of course, the inflammation is a reaction of the tissue to injury, and it's a at the end it could be either a repair or it could be the lysis, like the substances which are producing the cause of the inflammation may have to be dissolved and then they have to be expelled out, and they are expelled out by the fluid consistency, like what we call as the pus. Now, very specifically, inflammation produced due to bacterial organisms, microorganisms, is called as infection. Now, as far as this is concerned, infection is concerned, like suppose one bacteria enters into the body through a gap, maybe, or maybe the hematogenous spread. Now, there could be two forms of the spread. Either it could be inflammation or the source of organisms. In case of infection, it is the organisms which enter in. They either enter into the body from the external source or they could be from the hematogenous source. But once they start multiplying in the tissues, the phagocytes, the cells of inflammation, mediators of the inflammation, they come in and then they try to invade. And there would be a fight rather. Inflammation in such condition, there would be a fight between the organism and the cells. Now, defense cells. If that the end of the fight could be anything like, see, either if it is a situation where the body cells they are able to contain that inflammation, that organisms are controlled, then there will be a fibrous tissue formed around. The area of inflammation will be limited by a border of a fibrous capsule. So if there is a fibrous capsule formed around and the fight is limited to a area where the organisms are contained, and then during that fight some of the phagocytes they may be dissolved or they may be killed, some of the organisms will be killed, many products of the regeneration are produced. All of these together are called as a pus. So when you have a pus formation, and then a fibrous capsule is formed. The area is localized. Now, whole purpose to say this is there is a localization that's called as an abscess. So, when we say an abscess, there are important two features of the vidradhi. One is that the surface would be swollen because of the pus formation, and the other is the borders, barriers, and hence the shape is palpable. But when we say vidradhi, it's about the depth of the condition, where it could be deeper than the tokrata, mamsa, and so on. Whereas when it is limited to the tok mamsa, superficial area, then it is called as vrana shofa. So that difference in the nomenclature is a quite important issue. And on an average, the formation of an abscess could occur in 6 to 14 days. Now, one of the possible termination of the infection could be a abscess formation, and then the pus may get expelled out, and then of course the whole thing may heal with a scar formation. Or the other possibilities are there could be a inability of the cells to contain that fibrous capsule may not be formed, and it may not be sufficient to control. There is a tendency for the infectious organisms to spread beyond the area. Then it's called as a cellulitis. We use the term cellulitis or a failure of localization. A failure of localization is called as a Visarpa. Sushruta has identified this as Visarpa. That mechanism of localization in the microscopic picture, like once the abscess is formed, the abscess which will have a liquefied tissue, then at the border you will have that fibrous tissues, then of course the other tissues like the muscle tissue, and the granulation tissue is seen in the border, and a diagrammatic picture again to confirm to highlight that portion of the localization, phenomena of localization. I have shown you this picture. Like in an abscess, you will have a pyogenic membrane which is not really cellular, which is really hardened or maybe precipitated chemicals, protein and others. Then the granulation tissue, which is the real fighting tissues. Granulation tissues are the fibrous tissue plus the phagocytes and so on. Mature these fibroblasts, they will be in the periphery. Younger fibroblasts will be in the core. So outer surface of the abscess will be having mature fibroblasts and fibrocytes rather. The inner core will be having a younger or a new generation of the fibroblasts as such. Now, the same point is described in Sushruta. Again, it's a going back to what we have discussed in the Sutrasthana. Shofasamutthanah granthi vidrati araji prabhase prayana vyashiv abhitaha aneka kritaha तैः विलक्षणः पृथुः ग्रथितः समो विषमः त्वं मांसस्थायी दोषसङ्घातः शरीरेकदोषस्थितः शोप इत्युच्यते. Shofa is when the surface is or the area of the information is somewhat flat and it's related to Tvam Mamsa, superficial area, then it's called as the Shofa. When the same has failed to get localized, Tvam Mamsa Shonitagataha Kupitas Doshaha Sarvangasarinam, when there is a tendency to spread beyond that area, and iha astitam atmalingam. At one area it may produce the atmalinga, the science of information, and vistrutam munnatam ashushopam tam sarvato visaradacha visarpam ahuhu. Visarpa is the term used for such a situation where there is a failure of the localization, and hence there is a tendency for the lesions to spread beyond that area. Now, so this phenomena has to be very clearly understood, and this shows the clinical maturity of the social semester, the understanding of the information and the consequences of the information. Now, the same, what I say as abscess, cellulitis, erysipelas, these are the terms used. Cellulitis is where there is a tendency for the infection to spread to the deeper plane, and we will use the term different terms depending upon the plane of the tissue which is involved. Like if it is involving the fat tissue, you use the term necrotizing fasciitis, or it could be the further necrotizing changes in the muscles or so on. Erysipelas is when there is a horizontal spread. The cellulitis tend to spread in a horizontal manner and might not go beyond the adipose tissue plane, but superficial, then it's called as erysipelas. Abscess is well localized. So this is about the Vranashofa and the Visarpa and the Vidradhi. That has to be very clearly understood. Now, again, to highlight again the same issue, When there is a inflammation in the initial stage, what we call as a acute inflammation, then the fibroblasts would be lesser. You will have more of the phagocytes. Now, at that stage, it still could be having a tendency of the viscerpa. Whereas in a chronic inflammation, when it becomes chronic, there will be fibroblast formation, and the fibroblast will contain that inflammation, and hence it could be considered as a vidradhi. So, viscer, Ranashopa and vidradhi also can be made out with the microscopic examination. The difference between that acute and the chronic inflammation, same thing which we have discussed again in a methodical manner. In case of the acute infection, it could be either the inflammation rather pathogens or injured tissues. Chronic, it's a persistent acute inflammation due to non-degradable pathogens, and the pathogens have become non-degradable, cannot be removed. Then it's a chronic inflammation. Or persisting foreign bodies, or autoimmune reactions also can produce chronic inflammation. Now, chronic inflammations of that sort, where they tend to spread, remain as such, may be now categorized as other Shofasamuthana Vyadhi, Granthi, Vidradhi, allergy, and so on. Now, that's the point which we will discuss later on. So, different types of the chronic inflammations may be named with the different names based upon the conditions. Vranashofa is for the acute inflammatory pathology. That's the basic issue. Then, of course, the other cells involved are, now from the microscopic point of view, you can make out now these Pranashopa and Vidradhi or other Shopasamuthana Vyadhi by microscopic examination, where when neutrophils and mononuclear cells are involved, it's a Pranashopa, and when the other cells are involved, it could be any other variety. I am not saying only Vidradhi, it could be any other variety of the Shofasamuthana Vyadhi. So, Shofasamuthana Vyadhi are the chronic inflammatory conditions, or a few of the non-inflammatory conditions also are included in the Shofasamuthana Vyadhi. And of course, the duration is a short duration in case of the Vranashopa, whereas in the other conditions it's a long duration as such. Now, coming to these doshas bheda, Bhartaja variety of the Vidradhi is presented with the Krishno, Arunova, Parusho, Bhrisham, Atyartha Vedana, Chitrothana Prabha Kashta, Vidradhi, Vatasambhavaha. When the lesion has become blackish in color or bright reddish in color, and the area is somewhat rough and hard, pain is severe, that's called as the Vataja Vidradhi. Now, whenever there is an infection, one of the possible consequences of the infection could be the bacterial organisms, they are proliferating in the area, they may block the capillaries, and hence there could be avascular changes. The blood flow may get reduced. That tendency for the blood flow to get reduced can result in either a temporary vasodilatation in the periphery, and hence there will be reddish color in the periphery, as well as in the core area where the blood flow is completely blocked, it may become blackish or what we call as a gangrenous. So, a gangrenous inflammation, a virulent infection with the gangrenous changes, is considered as a Vataja Vidradhi. In the present day situation, we usually identify this kind of lesion in case of gram-negative infections. Now, the current approach would be based upon the type of the organism that you say these clinical signs, whereas from the Sushrutas point of view, it's about the doshas. So, when we consider this Vataja Vidradhi, when there is a really a vascular stasis or a vascular obstruction, it's a sort of many of these it's not that every time it's a gram-negative infection, it's a sign of a virulent infection which tend to produce a blockade of the vessels, and usually these conditions would have very rapid course and quite pain also quite severe, and the amount of the liquid pus is lesser. Instead, there will be a slough. It can be a thick slough which need to be debrided. Simple drainage would not be enough in such conditions. You can see such conditions quite frequently in the clinical practice. Whereas when there is a Pakko Udumbara Sankasha, Shavova, Jvaradahavan, Kshitrothana Prabha Kashta, Vidradhi Pitasambhavaha, when the Vidradhi is presented with them a reddish, soft appearing swelling like Udumbara Phala, then or it could be shower, bluish in color, and clinical signs of inflammation like toxemia, fever, and other symptoms are seen. And Kshiprothana Prabha Kashta, the course is rapid, that's called as a Pittaja Vidradhi. Now, most frequent variety of the abscesses which you see in the clinical conditions, they are of these conditions, which is called as the pyogenic infections. Pyogenic infections where the liquid pus formation is more, and most of the times, not necessarily, most of the times, the organisms are gram positive. So it's not a rule that the gram positive would be pyogenic and gram negative would be a necrotic. Not necessary. It could be both the ways, but on an average, in the majority of the conditions, it's the gram-positive organism. Of course, we make out the differences further on based upon the color of the pus. When the color of the pus is yellowish, it's a staphylococcus. When it is grayish and egg-like smell, it's the streptococcus, and so on. When it's greenish, it's a sign of maybe Escherichia coli like conditions. Now, the Kafaja variety of the Vidradhi, Sharava Sadashak Pandu, Shita, Sabdo, Alpavedana, Chirothana Prabhakasha, Sakandusha Kapotita, Kafaja Vyadhi would be a wide swelling, a flatter swelling, and comparatively signs of inflammation, local signs of inflammation like temperature being raised is not much as such, and pain also is lesser, and it becomes chronic. Now, such a condition is now used as the named as cold abscess. We use the term cold abscess. Or another of the similar condition which we can see is what we call as antibioma. Antibioma is a situation where a pus forming condition is treated with the antibiotics without proper drainage. Because of that, the contents will be sterile. Organisms may be destroyed, but still the abscess may persist. That's what you call as a sterile abscess, or maybe the cold abscess, or antibioma. Now, cold abscesses are often produced due to a non-pyogenic infective pathologies like maybe tubercular organisms, granulomatous infections where instead of the pus formation there is a granuloma formation that also can result in a cold abscess. Granuloma formation and the pus formation we have referred to in the Sutrasthana about that when we discuss Pranashopa, and where the organisms are not destroyed or not phagocytosed. Instead, there is always a localization effect. Localization is done by the giant cells, that's called as the granuloma, and that kind of a phenomena in due course of time can result in what we call as a cold abscess. So, cold abscess is a kaphaja vidradhi. Then Tanupita Asitasta Yesha Masaba Kramashakramat, the color of the swellings would be, these discharges would be, pus would be either thin in case of Vataja, Pita yellow in Pittaja, and Sita whitish in case of the Kapaja. Now, we attribute the color of the pus to the doshas, whereas in the present day situation, it is attributed to the type of the organism. In general, the vasoactive lesions they result in slough and serous discharges, tanu, and those conditions where pyogenic infections they may be either yellowish or whitish. Yellowish when it is staphylococcus, and whitish when it is streptococcus, and so on. And now, of course, you have the greenish colors and so on. So it all depends upon the same. Now, त्रिदोषज is नानावर्णभुजास्रावः घाटालः विषमो महान् विषमं पच्यते चाति विदधि सानिपातिकः. When the swelling has become indurated, now another of the important issue is the induration. Induration means when the extent of the tissue involved is more than what we can see. See, when you palpate, if there is a hardness felt beyond the area which is seeming to be abnormal visibly, that's called as induration. So, and that's exactly ghatala. Ghata word ghatala means also a wide piece of stone is called as ghatala, and a similar issue is considered as a ghatala. Now, and it's a bishamaha. The surface is irregular. Now, induration is a consequence of again a rather undecisive fight between the organism and the cells. At times, the cells are taking the upper hand. At times, it's the organism which take the upper hand, and that results in a extraordinary defense by the body. The fibrous tissues will be more, and the area of inflammation also tends to invade, and that kind of a situation is called as induration. Induration can occur either in case of a chronic inflammation, or it also can occur in tumor pathologies. So very often it's in the tumor pathologies that the induration is a very common feature. Even in case of chronic inflammatory conditions, induration can occur where you will have a mixed changes. Under the microscope, you will see hemolygenous spots as well as cellular elements, phagocytes, and the fibrosis. All these lesions put together, they may produce the induration, and the induration is always suggestive of a possible more complications as such, and that's why Sushruta has considered this as a Chidoshaja or Sannipataja. Now, तैस्तैः भावैः अभिहिते क्षते वा अपि अपत्यसेनः क्षतोस्मा वायुविसृतः सरक्तं पित्तमीरयेत् ज्वरः तृष्णा च दाहश्च जायते तस्य देहिनः एष विद्रधि आगन्तुः पित्तविद्रधि लक्षणः. Agantu vidradhi is when the source of inflammation or source of injury is from the external source, and it tends to spread into the body through a injury, and then further it spreads to the hematogenous blood flow. Vayu visruta saraktam, when there is an involvement of the rakta also. So Sushruta has mentioned about both these modes of the spread, like the external or the hematogenous, and when it produces a injury, the source is identified as an external, that's considered as a the agantu vidati, which has a similar symptoms as that of the pitta vidati. From the current point of view, current approach, in general, all organism invasion is considered as an external agent or a agent which is from the external, not as an endogenous. But though it's a general consideration, theoretically, it's true that many of the organisms can become an endogenous infection, like a commensal bacteria. Commensal bacteria is essentially in the body as a normal ingredient, and it is not going to harm. But when the commensal bacteria becomes opportunistic, now these issues like opportunism and commensals, again we have discussed during the Sutrasana discussion earlier. That's a organism which is otherwise friendly doesn't harm. If it becomes a harmful due to multiple conditions, then it can produce the septic complications. Sepsis can occur. So such a sepsis is a agantu vidrudi. Now, whether that the organisms, commensal organisms, have to be considered as endogenous or they are the exterior, this is a question of debate in the sense, because otherwise physiological they are different, they can be considered as an exogenous, but because in the normal situations they are essentially present in the body and they are the essential components of the functions of the body, we may consider this as an endogenous. So that point of the debate would be there. So I am not saying like you have only one side of the debate being very strong, but both the views have a validity. And when Sushruta says about the agantu vidrati, it's about the specifically the external sources, non-commensal organisms may produce the infective pathologies. Whereas majority of the situations, what we see in the clinical conditions, the most common cause of sepsis is the commensals becoming opportunistic, and they are considered as the doshaja vidrati. Now, Krishnaspotavradashyavah, Tivra Dahanujamjvaraha, Pitta Vidradhirindasto, Rakta Vidradhi Uchyate. Now, Rakta Vidradhi is when there is a Krishna spot, a blackish blood formed, and it's quite severe pain. This is about the virulent infections. When the infections become quite severe, rapidly growing, and again very frequently seen in gram-negative organisms. There could be more of serous collection of fluid, and that serous collection of the fluid can produce these blebs. And I think you might have seen these conditions clinically. And from the again contemporary point of view, all these are suggestive of a specific organism, but from Ayurvedic point of view, these are the signs of doshas. So it's a Raktaja Vidradhi. Rakta dosha involved, it produces that situation. That's about the external Vidradhis. Then Abhyantaran Atasturdham Vidradhim Pachakshare. And Abhyantara Vidradhi is when the organism or this Vidradhi infective pathology involves the internal cavities of the body like peritoneum, or it could be the thoracic area. Now, Guru Asatmi Viruddhana Shushka Samsasta Bhojanat Ati Vyayama Vegaghata Vidahivi Pratak Sambhuyava Doshaha Kupitaha Dulma Rupinam Valmikavat Samanardham Antat Kurvanti Vidradhim. The Andar Vidradhi is characterized by a swelling in the cavity of the body, abdominal cavity, and has a resemblance to that of the gulma. Now, we come to that difference between the gulma and the vidriti later. Gulmakaraha Swayam Doshaha Vidradhi Mamseshwanite. That's part also is a part of the discussion in the same chapter. We come to that part. So, though there is a similarity, a palpable swelling in the cavity, and maybe having a raised surface, that's called as the antarvidradi, the visceral abscess conditions. Now, clinical symptoms of these would be Bude, Basimukhe, Napyam, Vaksho, Kuksho, Vamshanayostara, Vrukayoho, Yakrati, Prihne, Hriye, Klomi, Vatata, Tesham, Lingani, Janiyasa, Bakhe, Vidrati Lakshanihi, Ama Pakveshaniya, Chapakwa, Pakum, Minir the locations of these are Buddha, Bastimukha, Nabhi, Kukshi, Vamshana, Vrukka, and Pliha, Hridaya and Kloma. And their features are something like that of the Vidhuti. In addition to that, there will be some specific features depending upon the area involved, and all these Vidhutis would have Ama and the Pakka Lakshanas as in case of the Vranashopa. In the Vranashopa, we have discussed about the Ama Pakka Lakshanas and the Pachamana Lakshana also. And their symptoms are Adhisthana Visheshena, Lingam Shunu Visheshtaha, Bude Vatanirodhasto, Bastau Kritshapamutrata, Nabhyam Hikka Tatha Adobaha, Kukshau Marthakopanam, कटी पृष्ठग्रहस्तीव्रः वंशनोत्थेतु विद्रदो वृक्कयोः पार्श्वसङ्कोचः प्लीहिनि उच्छ्वासावरोधनं सर्वाङ्गप्रगः तीव्रः हृतिशूलश्च दारुणः श्वासो यकृति तृष्णा च पिपासा क्लोमजे अधिका. Now, Gude Vata Nirodhastu, when there is a ischiorectal axis, now axes around the anus area or rectum area, we now categorize them based upon the location into either a supraelevator when it's in the pelvic cavity, and the intersphinctic or ischiorectal within the sphincter level or ischiorectal, and submucosal and subcutaneous. These are what we call as the pelvic abscess conditions. Among them, the real pelvic abscess, supraelevator, where there is involvement of the visceral structures, very often complication of a perforation in the lower abdomen or any other septic pathology, it often results in the vata nirodha, constipation or obstruction of the flow of contents from the rectum. Whereas the ischiorectal and others, they are of some significance from the point of view of the fistula. In the case of fistula, we have referred to these issues. So when we say like Buddhagata Antarvidhuti, it's about the pelvic abscess, supraelevator abscess as such. Now, Bastav Kruchak Mutrata, when the pus formation is in the basti. Now, basti in the sense you may not have a real pus formation in the bladder, but a similar pus formation can be seen in the prostate, in the neck of the bladder. And in the neck of the bladder abscesses, that's the prostatic abscess, which is often made out only by the ultrasonography, and clinically it's presented with the same situation where there is a difficulty of micturition or maybe retention of the urine or occasionally blood stained urine and acute pain, severe pain in the area. Now that's the Krichalpamutrata. Bastigata Vidati. Basti is here not the bladder, it's about the urinary structures. And it involves maybe the prostatic conditions too. Nadhyam hikka tatha athopa kukshav marthakopanam. Now, Vidati can occur either in the nadi, that's the central abdomen, or anywhere in the abdomen. Now, intra-abdominal abscesses, they are again quite frequent conditions. Very often, they are a consequence of leakage of the contents, and we generally categorize them into two categories: acute peritonitis and chronic peritonitis. Acute peritonitis is not really localized, where it could be spread throughout, where rigidity of the abdominal wall could be a clinical sign, whereas when it becomes chronic sepsis, internal abscess, which could be as a consequence of gallbladder infections, appendicular infections, or could be perforations, and so on. Such a abscess is considered as the internal abscess or visceral abscess. Now, when a abscess or pus formation is in close relation with the diaphragm, it presents with a hiccup. A hiccup is a sign of involvement of the diaphragm. Sushruta has considered this as the Nabhigata, the Vidradhi. Nabhi, though the word meaning is umbilicus, still central abdominal structures can be considered, and very commonly subdiaphragmatic abscess just below the diaphragm, in between the liver and the diaphragm. When there is a pus, the clinical sign would be hiccup. Hiccup is the major clinical sign. Sushruta has identified this as Nabhigata Vidradhi. Now we call it as a subphrenic or subdiaphragmatic abscess. Then, in case of the internal, the visceral conditions, when the mesenteric or any other area, it results in clinical symptoms of pain, swelling, and then, of course, a partial obstruction to the flow of the contents, intestinal obstruction, fetus. Marthakopanam. So, it's exactly the same symptoms which are seen in now also. The only thing is the level of description and the investigation facilities which we have are more facilitating the diagnosis. Of course, in case of abdominal conditions, abscess conditions, ultrasonography is a benchmark or rather golden investigation, like to make out the diagnosis. Then, Vangshanotha, when the Kati Pustagraha, the patient would have a spasm of the thigh, resulting in a position where the thigh is kept flexed and extension would not be possible. This is very typical of what we call as the psoas abscess, iliopsoas abscess. Again, one of the common conditions. When there is a pus formation in the iliacus area, iliacus muscles, it may just connect to the trickle down to the psoas sheath, and you may have an extension of the pus formation in the femoral canal, and this results in the spasm of the iliac and psoas muscles, and iliopsoas muscle spasm results in a leg kept in the flexed position. Kati Prishtagraha, the exact clinical description of the iliopsoas abscess in case of Vangshanotha Vidradhi. Vrukkayoho Parshvasankochaha, a subnephric abscess or perinephric abscess, abscess around the kidney. The clinical symptom, of course, would be the first symptom would be severe pain, and that pain results in spasm of the paraspinal muscles. And because of the spasm of the paraspinal muscles, the typical position of the patient will be bending towards the side of the lesion, and there will be a palpable swelling. At that area, there will be a palpable swelling. When there is a palpable swelling in the lumbar area, and the patient is bending towards the same side as that of the swelling, is a sign of an inflammatory pathology and usually perinephric abscess. Of course, later on that perinephric abscess can result in more complications like involvement of the renal functions and so on. But from the clinical point of view, a correct diagnosis would be done by either ultrasonography or MRI scan. MRI scan is necessary. Sushil had made out with the simple clinical sign of Parshvasankocha, spasm of the muscles. Then pre-utrasa avarodhanam. When there is a splenic pathology, abscess in the spleen, it results in the distress of respiration. Now, it's not only about the pleha. In the or spleen, any of the subdiaphragmatic structures having the inflammation, the respiratory catch sign is one. From the clinical point of view, because splenic abscesses are less common, whereas gallbladder pathologies are more common, we use that clinical sign of a respiratory catch, Utthasa Avarodhana. Respiratory catch sign is now considered as a standard sign of the gallbladder pathology. But it's not necessary that it's only the gallbladder pathology. The same is true in case of the left-sided condition like splenic abscess, but as the clinical conditions of splenic abscess are less common, gallbladder pathology are more common, we attribute this respiratory catch sign to the gallbladder. So if you look at the textbooks of surgery, respiratory catch sign is attributed to the gallbladder generally. But it's also true that a similar sign can be elicited on the left side, and then it's a sign of splenitis, inflammatory pathology. So whatever Sushil has said is absolutely clinically correct, and it's a simple clinical sign of eliciting the tenderness by making that inflamed part move over the other normal area. Sarvanga Pragaha Tivra Hriti Shulashdavarnaha. When there is a generalized systemic involvement, then it's a complication produced due to the Hridayagata. Hridayagata Vidradhi is a pericardial effusion, a fluid formed in the pericardium. And the causes of the pericardial effusion could be many. But of course, infective is one. Non-infective pericardial effusions can also occur, as in case of the congestive cardiac failure and so on. Autoimmune disorders also can produce a pericardial effusion. Now, in all the pericardial effusion conditions, the most important clinical sign would be like the because the heart is not able to pump more, there will be circulatory incompetency. The circulatory ability would be lesser, and of course, the clinical sign will be either reduced or absent sounds of auscultation, and the apex beat also is not being palpable. Or radiological signs will be widened pericardial shadow or By ultrasonography or echocardiography, we can make out exactly the amount of fluid, even quantitatively we can measure that. Now, so that Sarvanga Pragraha is about the involvement of the total vascular capability. The vascular capability would be lesser in case of the pericardial effusion. So all pericardial effusions can be considered as a Hridgata Antarvidruti. Shato Yakriti Trasnata, Yakritgata Vidruti, a hepatic abscess. Now, as we have discussed earlier, the incidence of the Yakut disorders mentioned in Sushruta or in Ayurveda etc. are very less. And one of that is the Yakut Gata Vidyati. And the description given is very brief. There is a breathlessness and a thirst as the abscess, signs of the abscess. Of course, signs of the abscess in the liver are mainly the toxic signs and the tenderness in the right side. And palpable swelling at the area. Of course, confirmation when you do the ultrasonography that confirms the abscess formation. Either it could be a single compartment or multiple compartment. Based upon that, we identify whether it is a bacterial or a protozoal. That's all the issues. Then chromaja, the nephric abscess, involvement of the kidney. Involvement of the kidney, nephritis and is now subnephric, perinephric abscess and nephric abscess. These are the two conditions. Nephric abscess is where the pus is formed within the kidney and the kidney tissue destruction is quite prominent, and kidney tissue destruction will always result in renal insufficiency, whereas perinephric abscess, the kidney tissue destruction is indirect due to the compression effect, that there is a impairment of the kidney functions which may recover, whereas in a perinephric abscess the kidney cannot be salvated. So that's all the point difference. And the pus is formed within the kidney itself. Incidence wise, perinephric abscess is more common than the nephric abscess, but occasionally it can occur. And now to differentiate that, you need MRI scan, whereas Sushruta had made out by the clinical sign of pipasa, excess of thirst. Sign may be one of the early signs of renal involvement, impairment of the renal functions. Of course, later on you will have more of the signs which are not really included. Now, anyway, that's about the undervitary. Amuma yadiva pakko, mahanva yadiva itaraha. Sarvo Marmothirashchapi vidradhi kastautyade. Prognosis of the vidradhi can be mentioned by different criteria. One of the criteria is the location of the vidradhi. If the vidradhi is located in a vital area, marma, and then the prognosis is poor. So depending upon location, like an abscess which is in the brain would have a poor prognosis, abscess on the surface of the body would have a better prognosis. Then, in general, once the pus is formed, the pus has always a natural tendency to get drained out through the path of least resistance. So, when the pus is formed towards the surface of the body, it tends to move towards the surface, and there could be a spontaneous expulsion by having an opening, or if the resistance towards the periphery is lesser, it may trickle deeper to the body. So, like a abscess on the abdominal wall can get extended into the abdominal cavity, and the pus may get drained into the abdominal cavity. Anyway, once the pus is formed, there is always a tendency for the pus to move towards the path of least resistance and get drained out. So all that what we do in the treatment would be facilitate the drainage by making an incision so that the pus will flow through a pathway which we would like to have it drain come out than the spontaneous. Now, uh, based upon this, like whether the pus will go to the exterior or pus will move towards the interior, the prognosis and the complications can be different. Then that's exactly what Sushruta has mentioned. Nabhehi uparijapakvaha yanti urdhum itaretvadah jivatyadho nisuteshu suteshu urdhum na jivati hrinavi dastivardhyayeteshu bhinneshu bashyatah jivet kadachit purusho nesareshu kadachana. Now this complication is very much true in case of visceral access conditions. In the visceral access conditions, chances of the pus coming out through the exterior to the exterior would be lesser. There is always a possibility of the pus trickling towards within the cavity. Either it could be from one cavity to the other, from the abdominal cavity to the thorax or thorax to the abdominal. Most frequently it is the abdominal cavity to the thorax. In case of the liver abscess, this is one of the possible termination combination complications, like a liver abscess may rupture into the pleura and then produce a respiratory distress. If at all it produces a bronchopleural fistula and the pus drained out, the patient may survive. Otherwise, there could be acute respiratory complications. Now that's exactly what Sushil has mentioned. If there is an abscess present or a vidradhi present in the superior part of the abdomen and it tends to rupture into the pleura, it can produce fatal complications. So a urdhva, if the pus moves towards the superior surface, then the prognosis is extremely poor. If the pus gets drained into the abdominal cavity, then it may produce a peritonitis. That also is not a optimum condition, but it may not be as serious as that of a pleural effusion. And that peritonitis could be the other complications. And in that condition, with your rigorous management, the patient may survive. Prognosis is somewhat better. But if at all the pus gets drained to the exterior, if it gets drained to the exterior through the abdominal wall, which is a less common incidence, or most of the times we prefer it to that way, we may make a incision and drain out the pus from that area, then that patient may survive. Jivet kadachita. But if at all the pus abscess is formed in the hridaya or that pericardial effusion or nadhi, basti in the prostatic area, even that external drainage can be fatal complication. These are critical conditions. That's what Sushila said. Now, the same transperitoneal and subcutaneous rupture of the liver axis, the same liver axis, it may just spread out into the rupture into the peritoneum and may produce a peritoneal effusion, peritonitis, as you see, or it may subdiaphragmatic into the superior area, and through the diaphragm the leakage may occur and result in a pleural effusion as such, which can be made out with the MRI scan or ultrasonography. Now, स्त्रीणाम् अपप्रजातानां प्रजातानां तथा अहितैः दाहज्वरकरः घोरः जायते रक्तविद्रधिः. Raktavidradi is a purpureal sepsis, a septic complication produced after the either delivery or abortion, apaprajata or prajata, after a normal delivery or an abnormal delivery, which presents with the sepsis symptoms. That's called as a raktavidradi. It may not be localized, it may not be seen as a local swelling, but when it is seen as a localized swelling, that's called as makkala. अपि सम्यक् प्रजातानाम् अस्य कायादनिष्ठितं रक्तजं विदृतिं कुर्यात् कुक्षौ मक्कलसन्निधं सप्ताहात् नोपशान्तश्चेत् ततो असौ सम्प्रपच्यते. A makkala is a retention of either products of inflammation, or it also could be a septic complication that it is localized. Now, Rakta Vidriti and Makkala, technically, though they are very similar conditions, there is a difference. When it is Rakta Vidriti, it's not a localized swelling, where the systemic toxin symptoms are seen. When it is localized, that's called as Makkala. And the general rule according to Sushruta is Saptahat no Prashantaha. If it doesn't subside within 1 week, then it can result in a purulent condition, suppurative condition, and which needs a rigorous treatment and prognosis is poor. As well as the current situation, purpureal sepsis is one of the serious issue, and generally they is defined as something which occurs within 42 days. Now, Sushruta has said Saptahat, 7 days criteria to identify these purpureal sepsis conditions. But now the WHO criteria is 42 days of delivery. If there is a septic complication within 42 days of delivery, that has to be considered as a purpureal sepsis. And it's according to the WHO again, it's one of the major causes with the causes for maternal deaths. More than 3,58,000 deaths yearly occur due to this issue, purpureal sepsis, and purpureal sepsis is a very serious issue. We stop at that level, we will not go beyond that. Later on, when we go into the treatment, there again we may have some more discussion about this issue. Now, the next part is about the difference between the Vidradhi and Gulma. Both of them are palpable swellings, and the differences are Vishesham atha vakshami spastam Vidradhi Gulmayoh Gulma dosha samutthanaat Vidradehi Gulmakasya ja kasmanna pachyate Gulmaha Vidradhi pakamedja न निबंधोस्ति गुल्मानां विदधि सनिबंधनः गुल्माकाराः स्वयं दोषाः विदधि मांसशोणिते विवर अनुचरो ग्रन्थिः अप्सु बुद्धुदको यथा एवं प्रकारो गुल्मस्तु तस्मात् पाकं न गच्छति मांसशोणितबाहुल्यात् पाकं गच्छति विदधिः मांसशोणितहीनत्वात् गुल्मः पाकं न गच्छति गुल्मः तिष्ठति दोषे स्वे विदधि मांसशोणिते विदधि पच्यते तस्मात् गुल्मश्चापि न पच्यते. Now, when there is a gulma, it's a sign of distended structure. Now, this is a part which we discussed when we discussed about Udara also. See, suppose it's a case of ovarian cyst. Now, let us take the example of ovarian cyst. Ovarian cyst in the initial stages is only that there is a fluid connected, otherwise, the anatomy of the cyst is not deranged significantly, and that doesn't result in aseptic complications or serious issue. If you just put in a needle and drain out that cyst, the things will recover. So that's exactly the Gulma situation. But suppose there is a septic complication and the cyst has or hemorrhage, torsion of the this ovarian cyst, it becomes or chocolate cyst where there is a bleeding and then the cyst becomes hardened, then the whole tissue is involved and it becomes later on it results in septic complications or the other vascular complications and so on. So then it becomes either a undervidrati or it could become a udara or so on. So depending upon that condition. Undervidrati is when there is a septic complication. Now, this situation is described by Sushruta as a situation where gulmakaraha swayam doshaha, a situation where the organ involved is not much involved, but it may be distended due to the accumulated products of inflammation or maybe the other entities, whether it's inflammation or non-inflammatory products, which are retained in an organ and the organ just gets distended but not there is a significant anatomical involvement. That's considered as gulma. Whereas when it results in a septic complication or the involvement of the tissue, then it can result in later on irreversible complications or septic complications. Then it is considered as the vidradhi or udara and so on. Now the only difference is from the present case point of view, we consider any of the organ or any of that pathology which results in a distension of the brain as a potential cause for the later stages. We consider these as the two stages of the disease, whereas social had considered these two as two separate entities. And that's a point which is quite amazing, like how Sushruta could make out this prior to that complications, whereas now we are accustomed to this kind of a thought process. So that's a real surprising issue and a point which I refer to when we discussed about the Udara also. Now, Hrinavi Bastija Pakwaha, Vardya, Eshta, Tridoshaja. In general, the abscesses or vidritis present in Hraya, Nabi, and Basti are Vardya and Tridoshaja also. Then the last part is about the Madhyaparipaka. Atha Madhyaparipaka Ghora Samupajayate. So Asthimamsa Nirodhena, Dwaram na Labhate Yada, Tasas Vyadina Tena, Jolanene Varushyate, Asti Madhya Ushmana Tena, Shiryate, Dakshamanavata, Vikaraha, Shalebhutoyam, Kleshayes, Aturam Chiram, Atha Astyakarmana Vyadhi, Dwaram Labhate Yada, Tato Medaprabham Snigdam, Shuklam, Shitam, Atho Guru. भिन्न अस्ति निस्रवेत पूयमेतद् अस्तिगतं विदुः विद्रविं शास्त्रकुशलाः सर्वदोषरुजाभम्. Now, when the same septic complication occurs in the asthi, the bones, the clinical signs of inflammation would be very rigorous. Now, from the current point of view, we name that condition where there is inflammation of the bone is a osteomyelitis. Osteomyelitis is again of two categories: acute osteomyelitis and chronic osteomyelitis. Acute osteomyelitis is often produced due to hematogenous spread of the organism, and there is accumulation of the pus between the periosteum and the bone as such, and because the periosteum is distended, that produces severe pain and severe toxic signs. There will be the clinical signs will be high fever and maybe increased cell count. Then really the local signs, local tenderness or pain may be or may not be very significant. Whereas in a chronic osteomyelitis, it's always exogenous source of inflammation, or maybe one of the later complications of an acute osteomyelitis, where the pus will find an outlet and there will be drainage, and that drainage will be a continuous drainage and shear drop sign, and maybe the bony separations also can occur. Necrosis of the bone can result in sequestrum and involucrum, new bone growth would be involucrum, so on. This complications would be different. Clinical presentation would be significantly different. Now, what Sushruta has mentioned is about the acute osteomyelitis. Madhya Paripaka. Madhya Paripaka is a acute osteomyelitis where the patient would have a severe septic complications and the pain will be quite severe. And one of the possible termination would be, now, in general, Whenever the patient has an acute osteomyelitis, the real serious issue is the toxemia. Patient may have a severe toxemia, and many of the patients may have a fatal complication due to the toxemia. Whereas a spontaneous rupture and then drainage of the abscess is or pus would be very rare. Where you need to intervene, you need to make an opening and then drain out because the periosteum is rigid. Because the periosteum is rigid, the pus will be in very high pressure and toxic absorption also will be very high. Now, Sushruta refers to a possible condition where the pus may get drained out. Pus may get drained out either with your spontaneously or maybe by the intervention. And if at all the pus gets drained out, then the patient may survive. Otherwise, he may not survive. This is exactly what is true. Now, with this, we end up this chapter. It is Sushruta Nidana30 vidradhinidana nama navamodhyayah, and we'll continue next session. If there are any questions, we'll try to answer, and then if there are few questions. Nephric abscess and pyelonephritis are the same. Now we use the term pyelonephritis where there is not per se pus formation. Non-purulent condition is a pyelonephritis. It's a infective condition, but the pus is not accumulated. No need of drainage there. Antibiotic treatment will be enough. Whereas nephric abscess is an abscess condition. As far as the clinical conditions or incidents are concerned, nephric abscess is less common, whereas pyelonephritis is more common. And in the pyelonephritis, clinical symptom will be urinary symptoms where there will be proteinuria and the cells present in the urine. Nephric abscess, local signs of tenderness, pain is the issue. Then can we consider partial sankocha of Vrukka Vidradhi as a obliterated psoas shadow in perinephric abscess? Okay, that's absolutely true. It's a sign. Now, when we can make out clinically the spasm of the muscles is seen, and in the radiologically, it's a obliterated shadow. That's absolutely correct. In your opinion, what is the understanding of cloma, sir? Now, of course, about the cloma, we have referred to when we discussed about the Ashmari and Basti. In the Ashmari chapter, I have referred to that issue. Uh, Now, Basti is the whole of the urinary collecting system, according to Sushma. Cloma is the real nephric renal tissue which helps in the formation of urine. Now, Sushma has not mentioned this specifically. He has referred to a Asankhya Adrishya Nadis which form the urine and from the Pakwashaya to the Basti. Now, this Asankhya Adrishya Nadi, that mass of that tubules, is what we consider as a kidney, and that's occasionally mentioned by Sushra as a cloma, probably. And more of that discussion about the cloma, whether it is the kidney or something else, we can discuss when we discuss about the Sharirasthana. Later in the Sharirasthana, you have plenty of opportunity to discuss about that. Then can you understand cloma vidradhi in the nephric abscess and vrukka vidradhi as a perinephric abscess? Uh, that's exactly the point I have told. Like I have told the same. Perinephric abscess is the vrukka data, and the cloma is of course, the renal abscess, nephric abscess. That's exactly the point we have told. Right. Can adrenal glands be included too? Yeah, of course, that's absolutely true. Adrenal glands, now about the cloma discussion. Now, adrenal glands may not be glands part of the cloma, but infective pathologies in the adrenal glands can present as a perinephric abscess. Perinephric abscess would result in involvement of the adrenal glands too. But from the clinical point of view, that's not a very significant event. It's also one of the issues. Of course, acute adrenal failure. In such conditions, perinephric abscess can be one of the triggering factors. So that part is true, but not directly cloma. And then about the cloma and the possibility of the cloma, we will discuss when we discuss about the Sharirasthana later. Right. So there are no more questions. So we'll end up today. And about the cloma, we'll have a good discussion during Sharira. Right? So, okay. Thank you.